Good morning, everybody. Welcome to Department of Medicine Grand Rounds. Today it is my privilege and pleasure to introduce to you Jennifer Lai, who's our visiting speaker. Yesterday she was a visiting professor in the Division of Gastroenterology and Hepatology, and today she is our Grand Round speaker. Dr. Lai got her undergraduate degree from Stanford University and then her medical degree from Tufts, where she also got an MBA. She then went to New York and was an intern and a resident at Presbyterian Hospital, Columbia, and after that then went to California, returning to California, I suppose, where she was a GI fellow and then a fellow in advanced transplant hepatology at the University of California, San Francisco, where she remains. She also did advanced training in clinical research while there, and she was appointed an assistant professor in 2012 and was promoted to associate professor last year. She has many awards in her CV, starting with her election to the Alpha Omega Alpha Honor Society. She is a prodigious researcher. She's very well funded. She currently holds an Oro 1 in investigating aspects of clinical decision-making in transplantation. She is generous with her time in the field of hepatology, being an associate editor of Transplantation from 2015 to 2017, and currently she's a member of the editorial board of Liver Transplantation, an associate editor of the American Journal of Transplantation, and on the editorial board of Hepatology, which may make you wonder, has she time to do anything else? But she has, and her CV lists 85 papers in peer-reviewed journals. She has made significant contributions to the field of transplantation, particularly in the areas of understanding our selection of patients for liver transplantation. She has really moved the field forward in understanding, recognizing, measuring frailty as an aspect of the patient with end-stage liver disease who might need a liver transplant, and is now moving on to the perhaps most difficult question: is how do we do something about it that reverses frailty? She spoke about that last night at GI Grand Rounds, but today she's going to speak about defining the limit of transplantation, a science or an art. So, Jennifer, thank you very much for coming to speak to us.
Thank you. Thank you so much, Dr. Lucien. Thank you all for coming this morning. It's really an honor and my absolute pleasure to be here. Here are my conflicts of interest. So today I want to talk a little bit about something different beyond my own research in frailty in liver transplantation. I actually want to explore with you the science and the art of high-risk medical and surgical decision-making. It's something that I think is sort of inherently interesting to me. What I really want to explore with you today is the process by which we make decisions for our patients and with our patients, and sort of probe and sort of inquire and make us all think about how maybe we can make it more systematic. And over the course of this next hour, I'm going to be presenting to you a case of a patient, a very real patient. All facts are true about the actual case. And I'm going to be asking you to participate with a show of hands. During the course of this presentation, I'm going to be presenting to you some data to incorporate into your decision making. And I want to just reassure you there is no right or wrong answer, but I want you to really participate and just think about how you're making that decision. So I want to tell you a story of Ms. Davis. The only thing that's not true is her name. She's a 54-year-old woman with hepatitis C cirrhosis. And about a year ago, she presented to our liver transplant center with a MELD score of 16. With cirrhosis, she had ascites and definitely had an indication for listing for liver transplantation. Pretty well, though. We were able to control her ascites at that time. And then She did well on the transplant list, and another 9 months passed, so this is just 3 months ago. She comes back into clinic, and this time she tells you that she has foggy brain. She's been experiencing some memory loss. She has a little bit more ascites, so we increased her diuretics, and we also started her on some lactulose for management of, and rifaximin for management of her hepatic encephalopathy. And then more acutely, 3 days ago, she finds in her home, she finds that her legs and her belly are much more swollen. She actually, because it's very hard for her to move, she suffers a mechanical fall. And she does not present for care, though. She's a pretty tough woman, and she just doesn't want to go to the hospital. She thinks she can work through this. But then within this last 3-day period of time, her son actually wakes up to find her in bed, and she can't wake up. She's super yellow. And so he calls 911, and because she's frankly comatose, and she presents to our emergency room. So she's admitted immediately to ICU Bed 4. She's intubated. She's not on any sedation because she's so comatose and obtunded. On physical exam, she has no focal deficits. She's completely non-responsive to stimuli. She's hyperreflexic. She's got myoclonus, clear signs of hepatic encephalopathy. She's jaundiced and anasarchic. Notably, there's no appreciable muscle wasting on her exam, no wasting of the temples, nothing in the biceps. There is preserved muscle bulk. On laboratory exam, her platelet count is 25. This is not entirely inconsistent with her baseline, which is about 40, so it's slightly lower in this acute setting. Her bilirubin is 40. Her creatinine is 2.9. This is acute. Her INR is 3.4. Her serum sodium is 135, giving her a calculated MELD score of 40. And we find that her UA is positive, and it quickly grows out pan-sensitive E. coli. So probably the initiating insult to her entire presentation when she started developing lower extremity edema and anasarca 3 days ago. Now, of course, she's intubated and is not on any sedation, so the first thing we need to do is actually just make sure there's nothing in her head. And this is the CT scan we get. And you'll notice, we don't have to be radiologists to see something not normal. And our radiologist reads that this is an 8 millimeter hyperdensity in the left frontal lobe. It may represent foci of active extravasation. Given the lack of blooming on post-contrast sequences, a small vascular malformation is not excluded. So this is a problem for us because she has a MELD score of 40. She has clear signs of acute on chronic hepatic decompensation. She is listed for liver transplant. I, as the transplant hepatology attending, want to take her to transplant as soon as possible. But then I've got to deal with this. So I have to call my neurology consultants to see what is this and what do I need to do about this, and does this represent a contraindication to liver transplantation? And what our neurologist, and lucky for me, it was actually one of the most senior clinicians in the hospital, one of the most just one of those people who are just super well respected in everything, and an expert neurologist on top of that. And he says, yes, Jennifer, it could be a small intracerebral hemorrhage, but I don't think it is. I really favor this being a venous angioma. These are low flow, low pressure vascular lesions. I think we can all agree it's unlikely to be contributing to her altered mental status. And he says it's typically not susceptible to further bleeding under normal circumstances. What I really want to know as a transplant hepatologist, though, is it going to bleed during transplant when the patient may get even more coagulopathic? And he says, well, it's not like we have any data on this. It's not like we scan patients' heads every time they go into transplant. We have no idea how many patients go into transplant with a head CT that looks like hers. But I don't think it's going to bleed. So I don't think that it's a contraindication to transplant. But this is a place where you're just going to have to take a leap of faith on my recommendations, Jennifer. So what we do is that we manage her hepatic encephalopathy, we manage her UTI, and he says if it's not evolving on head CT tomorrow, I think this is going to be a venous hemangioma, and you should proceed with transplant, all other, if there's no other contraindication. So we do give her 4 liters of Go Lightly, and she puts out 4 liters of stool. And then she does have a change in her mental status for the better, but not hugely changed. She does now grimace to painful stimuli. There's minimal spontaneous movement, but at least she's less obtunded than she was yesterday. And then we repeat the head CT, and you can see it looks exactly the same. At this point, her blood pressure is stable. She is still intubated. We do appear to have good control of the infection. Repeat blood cultures are no growth to date, but her period of sepsis seems to be controlled. Her MELD score, of course, is still 40. She's got acute on chronic liver failure. That's not going to get better. This woman needs a liver transplant. So my question to you is, do we proceed with transplant now? Or do you think that this is the limit to transplant? Is her overall clinical picture the limit of transplant? No, you don't want to transplant her ever. Or no, you don't want to transplant her now. Or you might be a little bit worried and want a little bit more time and a little bit more information. Now, I know that not all of you are transplant hepatologists or transplant surgeons in this room, so let me give you a little data. So I told you that her MELD score is 40 or 40 plus. And that is a very important number for transplant hepatologists. The MELD score is comprised of a calculation from the bilirubin, the INR, the creatinine, and now the serum sodium, and it spits out a single number from 6 to 40 and plus, and it predicts death in the next 90 days with near perfect accuracy. I mean, it's as perfect as one can get in medicine, quite honestly. And here you can see the probability of 3-month survival by MELD score here on the x-axis. And you can see that as MELD score increases, your probability of survival in the next 90 days in the absence of transplant goes down dramatically. And our woman, Ms. Davis, has a MELD score of 40. Her probability of survival in the next 90 days is less than 20%, and given this very acute rise in her MELD score, I would say that we're talking about not just within the next 90 days, within the next 7 days probably. So the next tool that I want to provide you is a framework for transplant decision making, although I recognize not all of you are transplant clinicians, and so I want you to maybe think about how this might apply in your own field within just general medical decision making, particularly for high-risk decisions. And within this framework, I need you to think about a patient's vulnerability to adverse outcomes. And I want you to think about 3 patients, patient A, B, and C, all of whom have sort of the same amount of vulnerability to adverse health outcomes prior to the treatment you're about to give, and in this case, we're considering transplant for Ms. Davis. Now, these 3 patients are differentiated by the amount of vulnerability they have before transplant that's represented in the gray box, which I will call transplant non-responsive. These are the things that are not going to go away with a brand new liver. These are things like older age. These are things like multimorbidity, the diabetes, the coronary artery disease, the hypertension. Those are things that are certainly not going to go away after you give them a brand new liver, and may even get worse. Diabetes, for example, will get worse. Obesity will likely get worse after a liver transplant. Sarcopenia may get slightly better, but probably is not going to get a ton better after liver transplantation. Now, you can imagine after liver transplant, we get rid of the coagulopathy, the ascites, the encephalopathy, all of the stuff in the white box, so you're left with what's in the gray box. And then that determines the patient's overall outcome, and then also the patient's transplant benefit. So that a patient who is a patient A, where all of his or her vulnerability before transplant is sort of represented by stuff that's going to go away with a brand new liver, is obviously going to have very high benefit to transplant. And then patient C, who's actually sick because sort of vulnerable to adverse outcomes, largely because of long-standing diabetes or severe coronary artery disease. Well, that stuff is not going to go away after a new liver, and we'll have marginal outcomes after liver transplant. And I would argue that the benefit to transplant is going to depend on the patient and what the patient wishes. Okay, so now with this tool in mind, let's go back to our patient. So remember that she's stabilized. Her sepsis and her septic shock has been stabilized. She's still intubated. She still has this thing in the CT scan, which, although we have no data, our neurologist is saying, don't worry about it. And her MELD score is 40. Okay, so I'd like to just have a show of hands. Who is ready to proceed with transplant for this patient right now? And who is not quite sure and feels like, I'm just not quite ready, or that I'm never going to be ready? Let's see a show of hands. Okay, so more of you guys want to proceed with transplant. The only data I've presented to you is her risk of more death in the next 90 days. And I think you guys are very convinced by the neurology consultation that we don't need to worry about it. So absolutely, the candidate need, I think, is driving this decision. But a liver transplant takes another component, and you can't transplant if you don't have a donor. And so we have a little bit of time to think. So those of you who are not quite ready to make a decision, thank goodness we get some time to think. That's the beauty of being a medicine person. But of course, her MELD score is 40. She is the top patient on our transplant list, and a liver offer does come by. And this is a liver offer from a 39-year-old donor who died after circulatory death, 30% large droplet fat. This liver qualifies as a liver that falls under expanded criteria. Now, you have to make a decision now. You can either accept this liver offer or you can decline it. Now, I think there are lots of you who've already convinced that we should accept a liver offer, even though I didn't give you the liver offer, but you're ready to transplant this woman because you know that we are probably going to wake her up because we're going to get rid of her hepatic encephalopathy. Neurology has reassured us about this lesion in the head that's unlikely to bleed during or after transplant. And I think we're all very worried that she has a very high risk of death, and we cannot wait. Now, let me just tell you a little bit about this liver offer, though, okay? Because that might drive your decision that might change your decision. So let me talk to you about the spectrum of donor livers, that they're not all perfect. I wish they were, but they aren't. And when we think about risk of donor livers, we generally think about them in categories of either whether they pose a risk of graft failure after a liver transplant or whether they pose a risk of disease transmission after transplant. A liver that we consider ideal are rare, but these would be whole livers rather than split livers. These would be donors who died from brain death as opposed to circulatory death, young patients, and their cause of death being trauma. And these are considered the lowest risk livers, lowest risk of complications after liver transplantation. And then they're on the opposite side of the spectrum of risk of donors. You have the expanded criteria donor livers. These are older donors. They're fatty, so over 30% or higher is really a fatty liver. Patients who died after donation after circulatory death, and these livers have a very high risk of ischemic injury. And then donors with risk factors for having hepatitis C or hepatitis B or HIV. These are considered higher risk liver, or the highest risk livers. And then the standard liver, which is sort of not ideal, not expanded criteria, these are considered average risk. Okay, and then if you'll remember, the liver offer we have in hand from Ms. Davis is a fatty liver from a DCD donor. Okay, so back to the tool that we should use for transplant decision making. I want to just sort of put the donors and how that might drive outcomes into this framework and help walk us through this. So a standard liver is sort of neither ideal and neither expanded criteria, and so this framework works for the standard liver. You can just go vertically. One of my mentors when I was a fellow actually said a great liver is the great equalizer. And it can turn a patient C, a super vulnerable patient, it can wake them up so quickly, it can cure all of the white box stuff so quickly that it can even just make even the other factors you thought weren't going to be responsive to transplant, it can make them even better. These are amazing cases. They're the kinds of cases that turn medical students into transplant hepatologists and transplant surgeons. They're miracles, and they're amazing. But of course, an expanded criteria donor liver, which is representing an increasing share of the livers that are available, can turn even a patient who has no transplant no gray box, I should say, into from a patient A to a patient B, but still achieving acceptable outcomes. But as you can imagine, if we take a patient C and we give them an expanded criteria donor, we can actually make them worse after liver transplant, making their transplant non-responsive factors, and really we can exacerbate their transplant non-responsive factors, that resulting in extremely poor outcomes, arguably entering into the feudal place of medical decision making. Okay, so back to Ms. Davis, and some arguments as to why one might decide to decline. And we said that this is an expanded criteria donor because it's both fatty and from a DCD donor, that could result in delayed graft function, worsening coagulopathy transiently after transplant, and increasing the risk of hemorrhage in a woman who might not have any room to spare in terms of her brain lesion. She may not recover from surgery because of this delayed graft function, and it's possible that perhaps this liver might be better in another patient. Okay, who is still really driven by the factors under this accept and would like to accept this liver offer? Okay, and then who says no, we need to decline this liver offer? I'm about at 50-50 with some abstainers. Okay, abstainers, you can't abstain in transplant. You have to make a decision. Okay, so we at UCSF decided to actually decline this liver offer. We were very concerned about the risk of graft failure, and also she has a MELD score of 40, and so we felt like, and clinically she was stable. We felt like it's likely, we hope, fingers crossed, we're going to get another liver offer, because she'll be the next liver offer that comes by will go to her almost certainly. And indeed, we get another liver offer the next day. And this is a liver offer from a 19-year-old woman who died from head trauma. Remember, head trauma is the most favorable way to die for a donor. And it was after a car accident, but the organs were preserved. Okay, so then if we look at these factors up here in terms of the accept and the decline, and focusing on the decline, this liver is going to work instantly. It's going to be so miraculously. And so the risk of delayed graft function is very low. The risk of having substantial coagulopathy during and after transplant is going to be very low. And therefore, if she has a brand new liver, she's very likely to recover from this acute event, acute decompensation, with a brand new liver. But of course, we don't quite address whether someone else could benefit more. This is the difficulty with transplant, is that you're never working in a bubble. There's always someone who can benefit more. But of course, we have to focus on Ms. Davis right now. So I'd like to see with a show of hands who is ready to proceed with transplant with this one. Oh, wait, hold on. I'm getting paged that one of our other patients is sick, so please come with me over to ICU Bed 9 with Mrs. Smith. Mrs. Smith is a 64-year-old woman with cirrhosis who's secondary to primary biliary cholangitis. She was admitted 3 weeks ago. Remember, Ms. Davis has only been here for 2 or 3 days with SBP and has developed hepatorenal syndrome type 1, which is, and we can't control it. It's a nearly fatal disease. And she's now in the ICU on continuous renal replacement therapy. She's been there for 3 weeks with a MELD score of 40. And you may wonder, well, why hasn't she been getting liver offers? Well, she has, except that she's tiny. She's 5'2", and she's basically, we can't find a liver the right size. So all the liver donors that have come by for her have been far too big to fit into this tiny little 5'2" woman. And now we're being paged because she's starting to ooze. The nurse cannot control the oozing from her CVVH line, her PICC line, her feeding tube is starting to ooze, and this is sort of the calm before the storm. Every transplant hepatologist knows this is trouble looming ahead. This is when the liver is saying, I've got nothing left to give. So let me give you some information about these offers. You may be surprised to know that actually the process of declining liver offers happens all the time. People not in transplant think, well, if you got a liver offer, you definitely take it because these patients are going to die. But in fact, even among those who underwent liver transplants, look at all the patients among those who underwent transplant, the average liver transplant patient received 3 liver offers prior to their liver offer that was finally accepted and got them to transplant. Among those who died awaiting liver transplantation, these patients received even more liver offers, a median of 6 liver offers prior to their death, which raises the possibility of whether death on the wait list represents truly a shortage of donor organs, or whether it is this process of maybe not being able to find the right liver, or more provocatively, whether it's we as clinicians turning down liver offers and perhaps not making, waiting for something better, but taking that risk that the patient might die in the meantime. Interestingly, the vast majority of those who died or were too sick for transplant actually received at least 1 liver offer prior to their death. Now, I also want to tell you a little bit something more that gives you some context for Mrs. Smith in particular. Women are at higher risk of death than men on the liver transplant wait list. You can see here very clearly that the women have the much higher cumulative incidence of death than men. There's actually a 30% increased odds of death over 90 days in women versus men on the liver transplant wait list, and this is due almost in large part due to their small body size. And you may wonder why is it such a big deal to have to be so small? Well, actually, women are sort of relatively short relative to the donor pool. So this is sort of the body size or the body height ratios of women and men on the liver transplant wait list. And most women are sort of in this 5'5" or lower range, whereas men are between 5'5" and 5'10"-ish. But most donors, deceased donors, are men. So 60% are men, and the median height of a donor is 5'10". So sure, we can put a donor, we can put a liver from a 5'10" into a 5'5", but if you're 6 foot and you're 5'2", like Mrs. Smith is, that liver is not going to fit. So let's go back to Mrs. Smith, who's 5'2", who just, this isn't going to her, except you know that Mrs. Smith is your next person on your wait list, because her MELD score is sort of the same as Ms. Davis. And so it is very likely that if you turn down the liver offer for Ms. Davis, the liver offer is going to go to Mrs. Smith. And she can stop waiting for 3 weeks. And also, you know that Mrs. Smith is now in this hyperfibrinolysis state, so you only have a couple days left. Okay, but the liver offer is coming to Ms. Davis. So, are you guys ready? For Ms. Davis, who is ready to proceed with liver transplantation? With this liver offer for Ms. Davis. I'm not offering splitting the liver in this case. That would be a great option. Very clever to split this ideal liver. And then, hold on. Oh, no. And then who is going to decline this liver offer for Ms. Davis? Largely because you want to give this to Mrs. Smith. Okay. I wooed you. I'm very passionate about these small women livers, so I'm glad I've convinced you. Okay. But I want to take you to another world, just an imaginary world just for a second, of sort of bioengineered livers. We are creating liver scaffolds. We are growing hepatocytes from pluripotent stem cells and cholangiocytes and grafting them onto liver scaffolds, putting them in pigs, letting them grow, and then able to procure them and transplant them. There is a world ahead of us. It's going to happen in the next maybe 10 or 20 years when we can start doing this, in which there is no donor scarcity. And of course, these are ideal livers. We're not going to grow non-ideal livers. And so now I want you to wonder and think about if we live in this world of bioengineered ideal livers in which there is no donor scarcity, in which someone else could, you don't need to think about Mrs. Smith when you're deciding whether to proceed with transplant for Ms. Davis. Who would like to proceed with transplant? And who just says, Mrs. Davis is too sick? Okay, I have consensus. Nobody does not want to give this ideal bioengineered liver to Ms. Davis. So let's go to the bedside. And of course, Ms. Davis herself can't consent to this liver offer, so we have to bring in her brother, Jeremy, who's sitting at the bedside. And we tell him, Jeremy, we have a liver offer for your sister. It is from an ideal donor, and it is her best chance to live. And Jeremy offers us something other than a yes. And he says, Doctor, our father passed away last year after a long battle with dementia. At the end of his life, he was fully dependent on us and wasn't his same self. My sister made it very clear to me that she would never want to live that way, nor would she want aggressive treatments if she wasn't able to have a good quality of life. Is she going to be able to achieve that with liver transplant? And so now we have to think, and it sort of puts a whole different spin on this decision. Is she going to achieve that with transplant? Should we accept this liver offer for her, knowing what our patient preferences are? And so I hope this case has given you just some thoughts about how we proceed with defining or deciding when to proceed with liver transplantation and when is the limit of transplant, and all of the components that go into that decision. Of course, we have to think about the patient's need for a liver transplant. What is his or her risk of death if she doesn't get a transplant? Is she suitable for transplant surgery? Is she going to bleed during the surgery? Is she going to make it through the surgery? Does she have cardiopulmonary reserve to get through the transplant surgery itself? But then in transplant decision-making, we also have to think, well, there's this another component of what is the quality of this donor liver? What's the likelihood that giving this donor liver, or if you're not thinking about transplant, you're thinking about a treatment, what's the likelihood that this treatment might actually make the patient worse rather than better, if at least transiently? And then, of course, in transplant, you have to think about donor availability. If I decide not to take this one, what's the likelihood that something else is going to come by in time to be able to transplant this patient? And all of these factors need to come together at exactly the same time, at exactly the right time, in order to make transplant happen. But as this case with Ms. Davis sort of showed, but we have a lot of data to inform us about these separate components. We have data, we have science that tells us what's the probability of another donor coming by in our area for this blood type at this patient's MELD score. Her MELD score was high. It's likely that another liver is going to come by. We have a lot of data on donor quality and what kinds of donors are likely to make a patient better instantly or make a patient worse transiently after transplant. We have a lot of data on candidate suitability for surgery. I mean, this is general patient suitability for surgery. We can investigate their cardiac function. We can investigate their pulmonary function. What's the likelihood they're going to make it out of the OR? And then, as I told you about the MELD score, and we have a number of other metrics about to assess candidate need, we know so much, and we have so much science behind assessing whether a patient needs a liver transplant. What is his or her risk of death in the absence of transplant? But the one factor that I think is really missing from our transplant decision-making, all of us were ready to make a decision about whether to proceed with transplant, but we hadn't yet figured out what the patient wanted. And I think this is oftentimes lacking not just in transplant medicine, but in general medical decision-making, particularly for high-risk medical decisions. And I think that largely it's because we walk in as clinicians with an assumption of what the patient wants. And in transplant, it's to live longer. Of course, if the patient comes in for a transplant evaluation, he or she wants to live forever or live longer than he or she would live with this cirrhotic liver, right? But I wanted to present some data from here. I don't know if Gretchen is here, but this is from Gretchen Schwartzy and her team. You guys are so lucky to have her here, and if you haven't heard her speak, please find any opportunity to go hear her speak. Her ideas are provocative and fresh and innovative, and she is an incredible speaker. And she did some very interesting work in this area and sampled and recorded 43 conversations between patients and surgeons prior to embarking upon a high-risk surgical procedure. And what she found in dissecting these conversations is that both the patients and the family and the caregivers who were present at the conversations largely assumed a common understanding about how to care for the patient in the event of a serious postoperative complication. And when I say assumed, it's that it wasn't discussed explicitly. Some representative comments were, my doc knows that we cross-country ski, we bike. So I think that whatever complication there would be, he would try to lessen it so that quality of life would remain close to the same. Another patient said, we didn't discuss it, but he knows, and he referring to the surgeon, he knows I don't want to be a vegetable. Common sense tells him that. So one patient wants to go back and cross-country ski, and that's his wish, and that's his expectation. And the other patient says, well, I don't want to be a vegetable, right? So this really represents a very broad spectrum of patients' preferences and wishes and expectations from this high-risk surgical procedure. And in fact, she and her team go on to sort of categorize patients into 3 different categories. There's the blind faith, the patient with blind faith. Representative comments included, no holds barred. If he's got to do something else, cut something else out on this side, might as well do it. I have complete confidence in that he would do everything that could possibly be done. These were the assumptions of the conversation. They were not things that came out of the conversation. They were not things that were explicitly discussed in these discussions between the surgeon and the patient and their caregivers. There was the sort of the denial group, the people who were sort of didn't want to think about it or were unaware of the risk. I realize that there's problems that could happen in anything, but normally they don't. Or, I think anytime you undergo anesthesia that there's always going to be risk. And then there was the fatalistic group. There was the, I'm not afraid of death. It's all the other BS you go through getting there. So this is a huge spectrum of wishes and expectations and desires that our patients express when they're about to embark upon high-risk decision-making, that almost never do we elicit in the conversations when we consent patients for procedures. For transplant, we actually get to know our patients very well prior to their transplant that very frequently we're not talking about. Interestingly, in this study of 43 conversations, there were 41 American surgeons and 2 Canadian surgeons, and it was only in the 2 Canadian conversations did sort of goals and preferences come out. Gretchen Schwartzy and her team also go further to really describe this new construct of surgical buy-in that I think is really important for us to think about as we embark upon these decisions. So surgical buy-in she describes as a contractual relationship between surgeons and patients that influences decisions regarding life-supporting therapy. It's the process by which the surgical team negotiates with patients a commitment to post-operative care prior to undertaking high-risk surgical procedures. One surgeon said, this is a package deal. This is what the operation entails. And it frequently leads to unwillingness to provide surgery or provide the medical treatment if a patient expresses desire to limit postoperative therapy. So 60% of surgeons said that they would sometimes or always refuse to operate on a patient if they expressed any preferences to limit life support in the postoperative period, so that they would not even begin to offer the high-risk surgery or the transplant if the patient said, you know what, if things don't go well, I want to be DNR, DNI. They wouldn't even offer that treatment. And although Gretchen and her team describes this as surgical buy-in, I think this very much applies to me as a transplant hepatologist, even though I'm not a surgeon and the other transplant hepatologists in the room. These are the conversations we're having with our patients. This is the sort of buy-in that we are vulnerable to falling into. At least at UCSF, if a patient is DNR-DNI, we don't offer liver transplant, quite honestly. Even though that sort of the concept of DNR-DNI didn't really apply to the transplant. It was sort of the patient's way of telling us, well, if things are not going well, if it looks like I'm going to be a vegetable, I don't want heroic life-supporting therapy. I recognize not all of you are transplant clinicians in this room, but I want you to think about some of the high-risk medical decisions that we're participating in with our patients. And I think this applies to a lot of other decisions that we make. Perhaps if you're an oncologist, could this apply to deciding whether to offer even one round of chemotherapy to a patient with metastatic cancer? If the patient says, I don't want to, I want to be DNR, DNI, would you even consider offering one round or trying to see how that high-risk medical treatment might work? So I think there are a lot of situations in medicine as internists that we face that really we might fall prey to this contractual buy-in. So as we go back to thinking about the components of defining the limit to transplant and also just the process of medical and transplant decision-making, let's go back to this one area in which we oftentimes have no data. That's really the art of medical decision-making. And let's see if we can put some science behind it and some data. And it's really as simple as asking yourself, if things don't go as planned, do you know what's important to your patient? And that requires us talking to the patient about, if things don't go as planned, what would you want? And so Jeremy, although we didn't hear from Ms. Davis, at least we can hear it very clearly from her brother. And she very clearly expressed that she would not want aggressive treatments if she wasn't able to have a good quality of life. And I think that really would apply to this transplant setting, that transplant would be an aggressive treatment. So do we think that she's going to achieve a good quality of life? Well, remember, Ms. Davis she's 54. Although she's had 2 years of cirrhosis, we've been able to control her complications. Her hepatic encephalopathy developed only 3 months ago, and then her acute presentation is actually rather acute. It was only 3 days ago, and although her MELD score is 40, although she's very sick and has no spontaneous movement, I think we have enough signs that this is probably from severe hepatic encephalopathy that will go away after transplant. And importantly, we didn't appreciate any muscle wasting on physical exam, suggesting that or supporting the idea that this whole presentation is very acute and not really the end manifestation of a very chronic process. So let's see if she's going to achieve a very high quality of life. And let's go back to this framework for transplant decision-making. And the thing that we need to decide is, with all the data that we have, is she a patient A, a B, or a C? And this is where some of the data from my research team starts to fit into the framework. I am the principal investigator of the Frailty study, which stands for Functional Assessment in Liver Transplantation, and this is my entire team. And in our functional assessment and liver transplantation study, we have been objectively measuring frailty and physical function and sarcopenia in patients with cirrhosis on the liver transplant list. And we've developed an index called the Liver Frailty Index that consists of a combination of grip strength, chair stands, and balance. And what we have found is that the Liver Frailty Index actually improves our ability to predict mortality in patients with cirrhosis. What we have found that above MELD score alone, remember I said MELD score is nearly perfect. Well, it's not entirely perfect. There's still room to move. And we have found that the Liver Frailty Index actually helps move the needle even closer to near perfect prediction. And in fact, the addition of the Liver Frailty Index to the MELD sodium score allows us to better predict deaths and delistings in 16% of patients, and allows us to better predict non-death in 3% of patients with cirrhosis, for a total net reclassification index of 19%. So in other words, 1 in 5 patients with cirrhosis on the wait list are better risk stratified with the addition of the grip strength, the chair stands, and the balance testing beyond MELD score alone, beyond metrics of liver function alone. Now, when it comes to post-transplant, does the liver frailty index predict how Ms. Davis is going to function after transplant? Well, what we have found is that going into transplant, 1 out of 5 patients will be robust. So 1 out of 5 patients is doing functionally quite well. Post-transplant, we get 1 more. So we get 2 out of 5 will be robust. But the only predictor of post-transplant robustness or frailty, either way, is actually how they were functioning pre-transplant. So as I illustrated here, the person who's robust pre-transplant is the one who's most likely to be robust after transplant. And so if we plot Ms. Davis, sorry, the formatting is off, but if we plot Ms. Davis along the liver frailty index histogram, so this is sort of the general liver frailty index of indices of patients with cirrhosis among 500 patients at UCSF, Ms. Davis actually had a liver frailty index when she was in clinic 3 months ago of 3.2. So in fact, she was robust 3 months ago. This whole clinical presentation is entirely acute. Her ability to not move right now is a reflection of her acute presentation, her acute hepatic encephalopathy, and not a reflection of years of having cirrhosis and ascites and portal hypertension. So I think what we can confidently say is that Ms. Davis probably doesn't have a whole lot of transplant non-responsiveness. She's not severely frail. And then we have a neurologist who says, you know, this thing is not going to bleed, and she also has no other comorbidities. So I think we can confidently say that she's not a patient B either. So she is a patient A. And so now, who's ready to proceed with transplant? And who is still saying, absolutely not, she's too sick for transplant? Oh, we got one. I'd love to get your opinion. Well, we have a majority, and so we agreed to go to transplant at UCSF for Ms. Davis. She did undergo a transplant. We had a standard donor instead of an ideal donor. She was discharged on post-op day 14. That's a little longer than what one would have expected, but not unreasonable for a MELD score of 40 patient. Her transplant was complicated by an anastomotic biliary stricture. She actually had to undergo a couple of ERCPs with stent exchanges, but it wasn't a big deal. That's a very common complication, and she was doing well. She was recovering at home with her family, with her son, and with Jeremy, and she was actually doing really well coming in for these ERCPs as outpatients. And then 4 months after her transplant, she was admitted with septic shock from cholangitis with Klebsiella, almost certainly from that stent. And it was complicated by DIC. She was in the ICU. We took her to ERCP. Biliary stent was exchanged. Her hemodynamics improved instantly once we exchanged it. She's back in the ICU. And then all of a sudden, the intern gets called that she vomited after her ERCP procedure. And she had a sudden loss of mental status. She couldn't be woken up. So, of course, we sent her to the CT scanner because she's completely obtunded instantly. And we found this. And knowing what we knew about her and what she wanted and what her goals and wishes were with transplant, we knew that this was the limit of her transplant. And sometimes that's what happens, is that the limit of transplant actually occurs after the transplant has happened. So my final thoughts is that I hope we now have a better understanding that the right decision in medicine should be defined by how we arrived at the decision, not by the outcome. And how we arrive at the decision must also incorporate the patient's preferences, which can feel oftentimes like the art of medicine, that sometimes it's a little bit nebulous, but if we all start taking a systematic approach to elucidating patient preferences with each patient for each high-risk medical decision-making, we can start putting some data and some science to that art. Thank you.
Thank you very much, Jennifer. We have some time for some questions. If you can repeat the question, because this is recorded.
I sum that question up?
So it's a question on what is the meaning of the doctor-patient relationship in determining how you make these decisions.
That relationship is absolutely critical. It becomes actually, in transplant, it becomes much more complicated because while a lot of our patients we do have a very long relationship with, as outpatients, some of our patients come in today and we need to make a decision while they're intubated about whether we're going to proceed with transplant. And I would say that doctor-patient relationship makes a huge difference in those decisions. The inpatient, who we really don't have a long-standing relationship with, who comes in for a new evaluation, almost frequently that decision is made unilaterally by the doctor. It's made purely on the data. Does this patient need transplant? Is this patient suitable for transplant surgery? And very infrequently do we have the opportunity to elicit the patient's preferences and what matters to the patient. But I would say at this moment, I think in transplant hepatology, I personally suffer from this. I frequently forget to ask the patient, even in the clinic setting, even when I've known them for a long time, what they're expecting, what they want from liver transplantation. And I'm hoping that this exploration of transplant decision-making will help start to plant those conversations or integrate those conversations into our routine management and outpatient management of patients awaiting liver transplantation that we're seeing, for visit after visit prior to their transplant, prior to their actual transplant, so that when we go into transplant, even if very frequently the decision is going to be the same, proceed with transplant, but at least we will know that if the transplant doesn't go very well, what would the patient want if the transplant doesn't go like we all want it to go?
Mark?
So, again, it's an excellent discussion, and I think you made a nice distinction between using science to lead to a decision while also incorporating the part of the patient, which is super important. I think the issue that in the bone marrow transplant area, we have a similar problem with collecting patients' thoughts about their preferences. And one of the concerns that we have is patient preferences vary. And like all of our preferences, and depending on their recent experiences, their global experiences, their family experiences, and whatnot. And so I'm wondering about your thoughts on how do you capture what is the mood of the day versus what values really are that might persist over time. I'll leave it at that.
The summary of the question is that patients' preferences vary frequently depending upon the current state of the patient. They may be feeling particularly unwell today with symptoms and therefore want less aggressive care versus when they're feeling well and they want more aggressive care. That is part of the art of this. I can only offer my thoughts, and I think that what's most important is that we have the conversation with the patient about their goals, right? I feel like, at least in transplant medicine, we're starting from a place where we frequently aren't even eliciting their patient preferences at all. And I also think that it's a start of a conversation to explore with the patient. Today, I know you're saying that you don't want more treatment, but what is it that's driving that decision? Is it because you're so nauseated? Is it because you're in so much pain? And if that is it, if that's what the patient tells you, then you can say, but I think bone marrow transplant or I think liver transplant is going to be able to get rid of that symptom. I know our patients have this terrible refractory ascites, right? And they have so much abdominal pain, and I can say, well, and they'll say, I can't do any more, doctor. And then you can say, but I just want to let you know that liver transplant will get rid of that symptom, that particular symptom. Or alternatively, I have patients who say, I have terrible back pain. I got in a car accident and this, the spinal stenosis is killing me. I want to just get better with liver transplant. And then I have to have the conversation and say, I want to be clear. Liver transplant is not going to get rid of that symptom. And I think the most important thing is that we just start this conversation, start exploring what is it that's driving patients' decision-making, and are those symptoms going to be the treatment responsive or the treatment non-responsive.
Last question up at the back.
I'm curious if your team conducts the frailty assessment in a hospital or an acute setting, or if you're just assessing it in clinic. And can you speak to why you either aren't assessing in the hospital?
So the question is whether we assess frailty objectively in inpatients or just in outpatients. We are only assessing it in the outpatient setting. And although assessment of inpatient frailty is critically important, I sort of think of frailty assessments, at least as borrowed from the field of geriatrics, as think of it parallel to creatinine. You know, if you see a creatinine acute rise, that creatinine today in the hospital doesn't reflect the patient's true GFR. Creatinine really should be used as a steady state. And I think a frailty metric like grip strength or chair stands is really a steady state metric. And so when you measure it in the acute setting in the hospital, it doesn't actually reflect the patient's true physiologic reserve like it would in the outpatient. But our team is, there's a huge unmet need of how to assess a patient's physiologic reserve and suitability for transplant surgery and ability to recover after transplant in the inpatient, and we are really brainstorming on metrics that might be suitable for that kind of measurement in the inpatient setting. My thought is that it's probably going to be something very objective, like a thigh ultrasound of the muscle or a CT scan to assess psoas muscle area, or some metric of sarcopenia that's going to get at the steady state frailty and not a performance-based test.
Well, thank you for that. Great questions, great answers, and let's give a round of applause to our speaker.
Thank you very much.